Hi everyone, Dr. Matt here, and in this video we're going to go through pharmacodynamics. In this video we'll first get a definition of what the term means, we'll get a brief overview of the concept, then we're going to come across and focus on the main modes of actions of how drugs work in the body, this being receptors, enzyme, transporters, ion channels, which is essentially the crux of what pharmacodynamics is. And then I've got a clinical example here of how I can underpin all of these different modes of drugs, of how drugs work. So here as our example, we've got the nociceptive pain pathway. I'll quickly run through the physiology of this, and then I'll illustrate to you the drugs that impact this pathway, being analgesic, how they work by these four modes of action. So here we go. So let's start with what the term means. Okay, so it's a compound word, a bit like what we saw with pharmacokinetics, but in this case we've got pharmaco, which is the drug, so that's the same as we saw with pharmacokinetics, but the dynamics is the difference. So dynamics means force or power. So what we're referring to here when we hear the term pharmacodynamics is essentially how the drug impacts the body, its power on the body, its force on the body. So when we saw pharmacokinetics was how the body affects the drugs, this being the absorption, the distribution, the metabolism, the elimination. But in this case, how does the drug, when it comes into the body, how does it impact the body? And this is essentially the mode of action or the mechanism of action of the drug in the body. So this is going to be the four ways that all the drugs that we use in pharmacology have an impact in the body. So it's important first to note that drugs will not create a physiological process that doesn't normally happen. It's either going to make it more exaggerated or block it. And the way it does this is by one of these four things: through receptors, cell receptors, through enzymes, which are catalysts in the body to increase chemical reactions, transporters, so this is to move things across, let's say, membranes, or ion channels, these is to shift charged molecules or charged atoms like sodium, calcium, chloride, things like that, so move them across a membrane. So let's start with receptors. Receptors they can be broken into four subcategories, which is ligand-gated, G-protein, enzyme-based receptors, or nuclear receptors. So let me go through these quickly now. So if I was to draw a cell, here's a typical cell in the body. It's got a membrane on the outside. Remember, a cell membrane is semi-permeable, which means it can let some things across, other things cannot go across. So in terms of receptors, a lot of them are going to be located on the outside of the membrane because this is the way you want to communicate with the cell. And a lot of these substances can't get into the cell, so they need to tell the cell from the outside to then do something internally. The first one is what we call a ligand-gated receptor. So what this means is you've got a receptor on the outside that is intimately connected with a channel. So binding to this receptor will open a gate, which is a channel, and then we can have the movement of something across the membrane. So examples, we might have a chemical called nicotine that binds to a ligand-gated receptor, opens a channel. In this case, the channel will be for sodium, so it's a sodium channel, and sodium then just wants to diffuse across its concentration gradient. So that we all know that sodium is higher quantity outside than inside, that therefore sodium will go into the cell and change the positivity inside the cell. So if this was a ligand-gated nicotinic receptor, it would, in this case, a skeletal muscle, sodium would rush in and then depolarize, which would then cause an activation of a muscle contraction. So that's a nicotinic receptor, and it's an example of a ligand-gated one. When we look at a G protein, a little bit more complicated. It's a protein that kind of weaves its way across the membrane in a long, like it's serpentine, looks like a snake, weaves itself across. But the difference with this one is it's got a second messenger, so another set of chemicals inside it. So if you bind here with a molecule, it will then activate a second message, which then will cause another kind of response. So this could be another gate, but the difference as we saw here, we have to activate this protein, which will activate a second message, and that second message will then go and activate that gate, and this could be calcium, so it could open a calcium gate, and then calcium comes in and enters the cell, and that could be the start of the release of a neurotransmitter. But the big difference between these two is that receptor's very intimate to the gate, and just by binding to that will open the gate, whereas G proteins require on a second messenger system, which usually requires ATP to activate that second message. Then we go to enzyme-based receptors. So you might have a receptor here that goes through the membrane, but underneath, instead of activating a second messenger with ATP, it activates a series of enzymes. So these enzymes go in this kind of cascade of manner and amplifies the response into the internal part of the cell. So instead of requiring a second messenger, this one requires a host of enzymes. And so these host of enzymes, an example would be tyrosine kinase, kinase being the enzyme. A good example of this would be insulin. Insulin binds to this type of receptor, activates a host of enzymes. The enzyme results in the production of glucose transporters, which come up and add glucose transporters to the cell membrane, and therefore glucose can then go and enter the cell. That would decrease glucose levels in the blood, but also allow the cell to become energized through glycolysis. So that's an example of an enzyme receptor. Finally, we have a nuclear receptor. Now this one's a unique because they are actually fat or lipid soluble, and they can actually come straight through the membrane. So they don't actually have to bind to a receptor on the outside. But in this case, they want to act inside the nucleus. So we know in the nucleus we have DNA. DNA are the genes, hold the genes to create proteins. So when you want to use a nuclear receptor, what happens is, say, some kind of molecule which is fat soluble can go straight across the membrane because it's lipid soluble. It can bind to a receptor in the cytoplasm. When it binds to the receptor, it essentially makes like a transcription factor, which can then go into the nucleus and change the expression of these genes. Can either increase the expression, so make more proteins, or decrease the expression, make less proteins. But in any case, the receptor is usually located in the cytoplasm or the nucleus, and that will essentially affect the way that genes are transcribed. So that's the receptors in terms of the mode of actions. We now look at enzymes. So an enzyme firstly is a catalyst. It increases the likelihood of a chemical reaction to occur. So it doesn't make a chemical reaction to happen that wouldn't normally happen, it just makes it more likely to happen. So a good example of an enzyme mode of action is what we call the RAS system. The RAS. This is the renin-angiotensin-aldosterone system. So what we have in our blood all the time is a protein called angiotensinogen. This molecule is made by the liver. It's always there, always in your blood. But we need to create an enzyme to change this. So the enzyme that we make, or the kidney makes, is something called renin. So let's say this enzyme looks a bit like a Pac-Man. And what it does, when you release renin, the kidney releases renin, usually in response to low blood pressure or low blood volume or a change in the osmolarity. This renin, I'll put renin here, which is an enzyme, comes along and chops a piece out of angiotensinogen. When it chops a piece out of it, it then changes its name. So now it goes from angiotensinogen to angiotensin 1. Now, angiotensin 1 does nothing in the body, so it's not really effective at all. But it will then meet another enzyme. So another enzyme comes along, in this case, another Pac-Man looking thing. But this one is called ACE. So ACE is angiotensin converting enzyme. It does a bit the same as renin, it just takes a chunk out of it, so it chops a chunk out. But now we turn it from 1 into 2. So these are catalysts. They are changing chemical reactions. Now we've got angiotensin 2. It's a very powerful molecule. It will change the diameter of blood vessels. It will tell the hypothalamus to release ADH. It will tell the adrenal gland to release aldosterone. All these things help blood pressure and blood volume. These are driven by enzymes, very important. The next one is transporters. So this is essentially just moving things across a membrane, so transport. We can sometimes see a transporter in the way that neurotransmitters work. So if we looked at nicotine, nicotine binds to its receptor and causes a response in the cell. But if you wanted to transport that nicotine back up into the first neuron, where it's released from, you transport it back up into the cell. This is done by a transporter. Sometimes it's taken off the receptor by an enzyme, and that would be done by cholinesterase, which is an enzyme to take choline off, or acetylcholine. So acetylcholine would be the neurotransmitter that works on nicotinic receptors. So acetylcholinesterase takes it off and is transported back up into the first neuron. So the transporters can work by that. Finally, ion channels are purely just channels on their own, not associated with a receptor. So in this case of the cell, you may just have an ion channel like a sodium channel, and this could be opened and closed by voltage. So this would be called a voltage-gated channel. And so if you open that receptor by a change in voltage, so as an action potential comes across a membrane like so, changing the volts can cause the channel to open, and we see that with an action potential on the neuron. So changing the resting potential will cause it to open, and then as it opens, sodium can go into the cell. And this is essentially how an action potential occurs. So ion channels can open in examples of chemicals or ligand or voltage. And in some cases of drugs, we can block those, and that can stop the ion channel working. This takes us to another important concept, which looks at how well the molecule binds to the receptor, or the drug binds to the receptor. This refers to a term called affinity. So affinity is all about how closely approximated the molecule binds to the receptor. This is a bit like a key and a lock mechanism. The better that the key fits into the lock, the more likely it is to work. So the better the affinity, the more likely it is to lead to a response. However, it's important to note here that sometimes we see a good affinity but no response, so no efficacy. If this is the case, we call this an antagonist or a blocker. So some drugs will actually bind well, but they won't cause a response. That would be called an antagonist. But if we see good affinity and good response, particularly like a maximal response of what can happen in the tissue, we call this a full agonist. Whereas if it's a submaximal response, so we see good affinity, but submaximal response, we call this a partial agonist. And I'll give some examples of full agonist, partial agonist, antagonist when I do this example. The final term that I think is important is what we call a competitor and non-competitor in terms of binding. So when we looked at the enzyme example down here with angiotensin converting enzyme, we could provide blockers, so antagonists, that could be competitive or non-competitive antagonists or blockers to this. So we have drugs called ACE inhibitors, so they block ACE, this enzyme, to activate angiotensin 1 into angiotensin 2, therefore helping with high blood pressure. So you could give drugs that we call competitive antagonists, and so these drugs would compete to angiotensin 1. So the drug would come in and kind of get blocked in the mouth of ACE, and then it can't bind to angiotensin 1 to cause the change into angiotensin 2. Because it's competing with this molecule for the binding side of the enzyme, we call that a competitive inhibitor. Whereas a non-competitive inhibitor would be non-competing with this molecule, but rather it might block or bind to the back of the enzyme, let's say, but binding to that part of the enzyme can change its structure, which then may change the shape of the mouth. It's important to note here that the enzymes don't have mouths, but this is just a metaphor that we've given here for the way it works. So by changing the mouth, it changes the affinity, it can't bind well, therefore it doesn't occur as an effect. So that is another example of how drugs can work competitive or non-competitive. All right, so that's hopefully illustrated to you different modes of action of how drugs work that underpin the concept of pharmacodynamics. Now I'm going to run through this clinical example quickly to try and go through all of these mechanisms that we went through. So here we have a finger that's just been hit by a hammer. We've got injury. This is illustrating that it's inflamed and throbbing. When we have this, this is called the nociceptive pain pathway. So it's taking noxious stimulus up to the brain that is perceived as painful. So we have the injury here, which activates C fibers and A delta fibers, which gets transported. So we have step 1, which is nociception. We then have step 2, which is transmission, and it's bringing through a nerve fiber into the back of the spinal cord, into the dorsal horn. Here we communicate with the first order neuron into the second order neuron, which then crosses to the other side of the spinal cord and is sent up to the brain. Step 3, we have perception, so the brain makes sense of the noxious stimulus and it feels the pain. What the brain can then do is modulate. This is step 4, which is sending a descending signal down to this synapse area in the spinal cord, which is now zoomed in here. And this descending pathway can send chemicals, neurotransmitters into that synapse, which can impact the way that that transmission happens across the synapse. So as the action potential is happening along the transmission nerve, so these would be happening with ion channels, which is we've seen here, voltage-gated sodium channels, which causes an action potential to go along that neuron. As it gets closer to the end of the first order neuron, what we will see is calcium entering the end of the synapse. Calcium entering would be across certain voltage-gated ion channels again. So now we're going to calcium. Calcium then would bind to neurotransmitters. In this case, they had to be excitatory. So like substance P and glutamate, that would go across the synapse, bind to the receptor. So we can see the receptor, probably going to be ligand-gated. Then we have a start of an action potential, and that's sending it on up to the brain. The descending pathway can actually send, because it wants to dampen the pain signal, so it can actually send neurotransmitters into the synapse, like opioids. So we have endorphins or enkephalins, and opioids can change the transmission potential of this synapse, as well as other things like noradrenaline or serotonin, which can also impact this whole mechanism, biochemical mechanism. So let's go through each one and we'll give examples of analgesics that work. So first one, ligand-gated. Remember, this is a receptor intimate to a gate, which changes the way that ions move across. So an example here for a ligand-gated analgesic is here on the receptor on the second order neuron, and this receptor is called GABA. And a drug that works here is Valium, or a benzodiazepine. So what happens is the drug given binds to this receptor, so it's a ligand-gated receptor, binds to GABA, closely approximated to a chloride channel. So in this case it's chloride. Chloride goes into the cell. Now because chloride's negatively charged, it makes the inside of this more negative. So the resting membrane potential lowers, which makes it much harder for this to be activated, hopefully improving pain, also helps with muscle contraction, so it's a muscle relaxant as well. So that's one example of an analgesic that can sometimes be used in a pain situation, and that's driven by a ligand-gated mechanism. The next one is a G protein. So we saw this here. In this case, the good example of a G protein mode of action drug, analgesic, is opioids. So an opioid could be, well in this case we have our own opioids like endorphins or enkephalins, but the common opioid that we take as an analgesic would be morphine. Morphine, we take it, it binds to the receptors here, so it's an agonist. So it binds to the receptor, activates the receptor, closes a calcium channel. So in this case, it stops the calcium channel opening, therefore we don't release the neurotransmitter. So I guess in that case, it's more of has an antagonizing effect because it closes a channel, okay, but it doesn't block the receptor. So it's not a true antagonist. But over here, what it would do is bind to a potassium channel, and that opens potassium. Potassium leaves, so potassium goes out of the neuron, makes this more hyperpolarized, which drops its resting potential, does similar to what we saw GABA, makes it harder to stimulate that. So morphine would be an example of a full agonist. Now, a partial agonist would be buprenorphine. So buprenorphine, also an opioid, but it has a submaximal response as compared to morphine. So it would still bind to these things, but doesn't produce such a maximal response. And buprenorphine can be useful to reduce addictions and certain qualities like that we saw with morphine. Now, we can do a full antagonist with opioids as an example. And an example of an antagonist is naloxone. So naloxone is a opioid antagonist. So we can sometimes use that when a person has had an overdose with an opioid and it blocks the receptor. So what it would do is it would come in and actually bind to the receptor with good affinity, but stop the response, and that can take the other full agonists off the receptor and then reverse the action that we saw with the overdose. So that would be a problem with opioids, like impact in respiratory depression, and the person potentially with an overdose of an opioid can stop breathing. So if by given naloxone, which is an antagonist, can reverse that effect. So that's the G proteins. Enzyme-driven receptors isn't really a mechanism in analgesia. Nuclear, this is a bit of a stretch as well, but an example of a nuclear mode of action drug could be cortisone. So cortisone is a steroid-based drug. It can sometimes be used in chronic pain, particularly when there's a lot of inflammation. So you could give a cortisone injection, let's say into the shoulder where there's chronic infection. Now what happens with cortisone, it crosses as a steroid and changes the gene expression of cytokines. Cytokines can create inflammation. So by reducing cytokines, we can decrease the inflammation. And like we saw over here, if you decrease the inflammation, you reduce the sensitivity of the pain receptors out here in the periphery, like in this case the shoulder, and that will then decrease the way that pain is transmitted and taken up to the brain. So that's all the receptors done as examples. The enzymes, so an example of an analgesic enzyme, we would work out here as an example. So if you hit your finger with a hammer, would cause injury and damage and death of cells in your finger. What would happen is certain cells like white blood cells, like macrophages and other cells that have been damaged, will create enzymes called COX enzymes, cyclooxygenase enzymes, particularly COX-2, and they produce certain pro-inflammatory mediators like prostaglandins and bradykinins. What these then do is sensitize the nerve and starts the signal down the pain pathway or the nociceptive pathway. So if you can block COX-2 enzymes, you can maybe reduce the pain sensitivity. Examples of drugs that can be used for this are NSAIDs. So these are non-steroid anti-inflammatory drugs such as Nurofen or celecoxib. They work by blocking enzymes, in this case cyclooxygenase 2, reducing prostaglandins, reducing the sensitization of nerves out in the periphery where the injury has taken place. So that's enzymes done. Now we move to transporters. So an example here would be serotonin. Serotonin, sent down as a modulation from the brain, can bind to its receptor, but its effect is actually it's a inhibitory neurotransmitter. So unlike substance P and glutamate, it actually inhibits this neuron sending a signal down along up to the brain. So it inhibits this signal. So serotonin and noradrenaline can actually inhibit that signal. But what would happen is that serotonin is taken off the receptor and taken back up into the neuron, so reuptaked into the neuron. And pulling the serotonin off the receptor and putting it back up into the neuron would stop its effect. So we can change the transport that does this. So these would be drugs called SSRIs, which stand for selective serotonin reuptake inhibitors. So we actually stop that reuptake, which means more serotonin is in the synapse, therefore more negative effect on the second order neuron, therefore we have reduced pain. So some drugs can work with serotonin, some drugs can work also with noradrenaline. This is kind of where cocaine works. Cocaine stops the effect of serotonin and noradrenaline getting reuptaked back into the neuron. Therefore, more is in the synapse. So that's the transporter. Lastly, we've got the ion channel. An example of an ion channel. So if you were looking on the first order neuron, Along here we have channels for sodium. Remember we spoke about sodium channels like here, voltage gated. So as the voltage is going along, it's opening voltage gated sodium channels. Sodium's going into this neuron, which causes the action potential. But if you can block this, you can block the transmission of pain. So some drugs will actually just get stuck in the voltage gated channel, like in here. These would be drugs like lignocaine. So these are local anesthetics, or nerve blockers. They block the effect of the voltage gated channels, therefore sodium doesn't go in, therefore no action potential, therefore no transmission, and they stop that transmission of pain. So there we have it. We've gone through what the term means, what the general concept is. We've seen the broad mechanism of action, receptors, enzymes, transporters, ion channels. We've looked at affinity, we've looked at agonists, partial agonists, full agonists, antagonists. We've looked at competitive, non-competitive inhibitors, and then we've looked at an example to underpin the whole concept of pharmacodynamics in pain and analgesia.